When the brain changes, behavior tells the story. That is the theme of this episode of the Neurokrish Immersion, Through the Looking Glass, which looks at the behavioral manifestations of brain dysfunction. Like Alice through the looking glass, the change in behavior can be familiar yet strange. Brain injury transforms the familiar into the foreign, not through memory or movement, but through behavior itself. There has been a paradigm shift over the years. The traditional view is memory loss in dementia, movement loss in Parkinson's, and speech loss after stroke. Our new understanding is that behavior can be the thing that changes first. In all these conditions, the personality shifts early in the sufferer even before the core manifestations of memory loss or mobility loss or speech loss evolve, and emotional alterations tend to precede cognitive decline. Behavior, therefore, acts as an early warning system, a window into brain function that opens before other symptoms appear. One condition that has become evident to us is what's called mild behavioral impairment. Now, we are all familiar with mild cognitive impairment, which is a pre-dementing stage, but mild behavioral impairment can whisper to us before memory starts failing. It's a change in personality and behavior which arises later in life, lasting for longer than 6 months and representing a change from the lifelong character. So suddenly the person is now different from what they used to be. Behavior in this way and in this condition can be the brain's first cry for help. A calm person becomes irritable. A meticulous homemaker starts to hoard sweets. An outgoing professional starts to withdraw, and these changes are well recognized. Now, mild behavior dysfunction tends to present across 5 domains. One of them is affective dysregulation, and this is about anxiety, depression, and mood swings that are starting to present themselves in an individual in later life, and this person has not been like this before. Another is impulse control, agitation, aggression, compulsive actions that the person starts to demonstrate. And again, this is unfamiliar to people who know the person. The third is apathy, reduction in drive, loss of initiative, emotional indifference, and withdrawal. Very often patients' spouses or family members tell me, oh, he just sits in front of the TV. He can't even bother to change the channel. And that is apathy. The fourth is social inappropriateness, loss of empathy, and boundary violations. Now, you are all familiar with this in terms of older people. Many older people seem to lack social filters when we look at it from the perspective of a younger age. But this may be a little more pronounced than just lacking social filters. And the fifth is abnormal thought and perception, where the person starts to have hallucinations, delusions, which are false beliefs, or paranoia, which is suspicion. These organized patterns help predict who will decline faster into dementia. In patients with mild cognitive impairment, mild behavioral impairment accelerates the journey into dementia. Now, think of a retired teacher who is known to have a good memory and a good integrated personality, a kind individual. Suddenly, while the memory remains intact, the person starts to engage in compulsive shopping. Thousands are being spent, and there's uncharacteristic irritability with the family when questioned. Here, MBI, mild behavioral impairment, which precedes cognitive decline, may well be the reason why this is happening. So a behavioral change, demonstration of uncharacteristic behavior, is an early warning sign. Behavior can whisper before the cognition starts to falter. We talked about apathy and there's a more serious version of it called abulia. Now, apathy is lack of interest or motivation. It's seen with depression, with dementia, with a range of psychiatric conditions. But there is an emotional component to apathy. I am disinterested, I withdraw, and I'm worried about the fact that I'm disinterested and withdrawing in many instances. Abulia, on the other hand, is loss of spontaneous behavior in itself. There is awareness, but the initiative is completely lost. And what the person describes is not sadness, but an emptiness. Professor C.D. Marsden, a very famous neurologist, in fact the most published neurologist ever, was a legendary figure in Queen Square, the National Hospital, which is known as the Mecca of neurology, where I also trained. And I remember him describing to us what we went on to call the golf test. This was a patient of his with Parkinson's disease who bought a villa opposite a golf course, outside a golf course, and would sit on the veranda and watch people playing golf, but could not get up from the veranda and go and play golf himself, although that was the reason, that passion was the reason why he ended up buying a house right outside the golf course. And this we came to call the golf test of abulia, that you don't have the will, you don't have the get up and go to do something. Now the distinction is that in depression, the person is distressed. I feel terrible. I want to feel better. I have emotional suffering as a consequence of what I'm going through. On the other hand, in abulia, which is seen with Parkinson's disease, the family tends to be more distressed. And the person says, I don't really feel anything. There is an emotional flatness. And very often this is accompanied by degeneration or damage to various critical brain structures. So when you look and see abulia, you must look for the caudate, the thalamus or the frontal lobe and see if there is damage. And one important clinical pearl is that you can treat depression with medication like SSRIs. Abulia does not typically respond to this approach. Now, stroke patients, for example, very often present with abulia, and there is a profound indifference, there is no real sadness or anxiety, and they need to be cued constantly to do simple things like eat or walk. And here we need to understand that this is a consequence of neurological damage. Now, quite the opposite of abulia, again something that we see in stroke, is what is called the pseudobulbar affect, which is really emotions being disconnected from feelings and the person's emotions being on a roller coaster. And how this presents is that you see the person weeping uncontrollably while feeling neutral, or indeed laughing loudly in a situation where they should not be laughing at all, say perhaps a bereavement or a funeral. And this is today known as involuntary emotional expression disorder. It's not at all rare. 75% of stroke survivors, 50% of people with dementia, 40% of people with traumatic brain injury have been known to present with these features of involuntary emotion expression disorder. And the way to recognize it, of course, is that the person has an outpouring of emotions in a situation where it's inappropriate to have that outpouring. And there are treatments for this. It does respond to various drugs, and it's very important to remember this because it can be a very problematic circumstance when it continues for months and years. Let's look at again the condition Parkinson's disease. Now we look at the triad of tremors, stiffness and slowness, what's called rigidity and bradykinesia. This triad of symptoms is what we look at as core of being Parkinson's. But Parkinson's carries a hidden behavioral burden. Depression and anxiety can often precede physical symptoms like tremors by years. Apathy affects up to 40% of people. REM sleep behavior disorder can appear years before the motor symptoms, and here the person acts out their dreams in their sleep. You will find people moving themselves violently, shouting, running out of the bed, and all these are features of REM sleep behavior disorder. And of course, the drugs that we give for Parkinson's, which are pro-dopaminergic, because what you're trying to do in Parkinson's is to replace the dopamine which is lacking, what they can cause is impulse control disorders or indeed compulsive behaviors, gambling, shopping, hypersexuality. And this, it's very, very important to watch for this outcome. Think of one of our patients, a banker with Parkinson's disease, but after starting dopamine agonists as medication for his Parkinson's, he developed this compulsive gambling. Indeed, he ended up losing a very large proportion of his savings. And what people needed to understand was that it was not a moral failing, but medication-induced behavioral change. Dopamine agonists like pramipexole can actually trigger this kind of an impulse control disorder, and it's important to watch for these soon after you have introduced the drug, or indeed one's dose has been amplified during the course of treatment. In Parkinson's, there is another kind of condition we see in what's called Lewy body disorder. It also presents as a form of dementia with Lewy bodies. And what we do encounter in these patients are vivid hallucinations. Indeed, I remember well a patient of mine who would fall off his bed. And when we asked him why, he said, oh, there were these children playing in my room and they were playing football. So I got down to kick the ball. So he actually had a very, very vivid hallucination of what we call a complex visual hallucinations. People with Lewy body often have good days and bad days, and the variations can be quite dramatic, and very often they have delusions of an imposter being in the room, what we call the Capgras syndrome. And of course, dementia with Lewy bodies or Lewy body disorder has an extraordinary reaction to the use of medicines like haloperidol, which are given to take away the hallucinations. The person becomes stiff as a board when these are given. So it's very important when you encounter complex visual hallucinations along with some symptoms of Parkinsonism to keep in mind Lewy body disorder or dementia with Lewy bodies. And of course, both in Parkinson's and in Lewy body disorder, there is a kind of continuum that we see. With Parkinson's, movement symptoms dominate. With Lewy body disorder, cognitive and behavioral symptoms dominate. With Parkinson's, tremor and rigidity are primary symptoms. With Lewy body disorder, hallucinations and fluctuations in cognition and behavior are the primary symptoms. In Parkinson's, the behavioral symptoms are secondary to the Parkinson's disease. So very often we see depression, anxiety, and even sometimes psychotic symptoms, but secondary to the Parkinsonism. Whereas in dementia with Lewy bodies, very often the movement symptoms are secondary. The pathology is the same, the emphasis is the different. And for many of these patients, what I was describing earlier, the dream enacted in sleep, REM sleep behavior disorder, may indeed be the feature. And again, to describe this, punching, kicking, shouting during sleep, dream content being enacted physically, these are strong predictors of future neurodegeneration. Indeed, the brain's mirror begins reflecting changes long before we recognize them. Behavioral symptoms, therefore, can really be biomarkers in some ways of brain degeneration or brain illness or brain injury. They offer us an opportunity for early detection because behavior changes often precede cognitive or motor symptoms by years. So when you see someone in middle age who is starting to present with changes in behavior, think of the brain, not just psychology. From a diagnostic perspective, behavioral patterns can point to specific brain regions, and I'm going to outline this a little more. We've already talked about Parkinson's, which comes from the basal ganglia, and dementia with Lewy bodies, which also comes from similar parts of the brain. There is an opportunity to plan treatment better when you understand the neurological basis of behavior. And of course, it's very important to educate families because this reduces stigma and blame for families and helps patients and families have a better quality of life. So when you encounter these behavioral changes, look beyond the obvious, try to localize the lesion, consider whether any medication that we are giving or indeed any other organic factors, for example, metabolic factors or infectious factors, are contributing to this. Recently, an elder we are looking after had a severe flare-up of his paranoia, and it turned out that his problems amplified. He already had some problems, including hallucinations. They amplified in the context of a urinary tract infection that had not been diagnosed. So it's very important to look for physical causes as well and medication effects. And of course, it's very important to listen to families because he is not himself anymore is a very astute observation that we need to follow in the clinic. When the brain changes, behavior becomes its most honest mirror, revealing dysfunction before memory fades or movement fails. From mild behavioral impairment to pseudobulbar effect, from abulia to Lewy body hallucinations, behavior tells the brain story with remarkable clarity. And therefore, looking through the looking glass, behavior is one of the first signals that we look for, and specific behavioral patterns localized to specific brain regions. Many behavioral symptoms are highly treatable when recognized, and understanding the neurology does reduce stigma and improve care. The familiar becomes strange, but through understanding, we can navigate the looking glass world with compassion and precision. Let's now look at another type of behavioral change that comes with frontal lobe dysfunction, what's called behavioral variant of frontotemporal dementia or the loss of social brakes. When the ventromedial frontal cortex and the anterior temporal lobes degenerate, social filters are stripped away, not from increased desire but from loss of contextual awareness. And of course, if you've listened to some of my other podcasts, you would have come across Luria's theory of why we have emotional discontrol. It's actually quite important to consider in this context as well. Now, in behavioral variant of frontotemporal dementia, the following brain regions are affected. The ventromedial frontal cortex, which controls social judgment and emotional regulation, the anterior temporal lobes that process social context and empathy, and as a consequence, social filters tend to get stripped away. Some features include new onset hypersexuality, often appears after the age of 50, and sexual behaviors that are contextually appropriate start to evolve at this stage. There's a loss of empathy. There is an inability to recognize others' emotions. The person is not able to understand why their behavior is inappropriate to context. For example, a relative, say for example a daughter-in-law, is the victim of the behavior that the person is manifesting, and the person doesn't understand why that is not right or why that can be problematic. And of course, other early warning signs include sweet cravings, compulsions, and hoarding behaviors. So a person who's, for example, a corporate leader who makes sexual remarks during a board meeting, or say disrobes when he's in clinic for an examination without being asked to. And of course, when confronted, the person tends to be genuinely puzzled. They no longer recognize why the behavior is inappropriate, not because of psychiatric illness, but because of progressive neurodegeneration. And therefore, remember these red flags for behavioral variant of frontotemporal dementia: hypersexuality, personality change, loss of empathy, and a progressive loss of insight. In an early stage, Sweet cravings, mild compulsions, and subtle personality shifts are what present. As the problem progresses, empathy is lost and contextual unawareness emerges. And in an advanced stage, there's complete loss of social filters and disinhibited behavior. And unlike psychiatric illness, this is progressive, and that's something that we need to keep in mind. Another condition that gives us insights into the brain and behavior is the temporal lobe. And temporal lobe epilepsy offers a unique window into how the brain creates experience. During seizures, patients may feel sudden terror, ecstatic bliss, or intense déjà vu. One of these syndromes is the Geschwind syndrome. It tells us how seizures can reshape the personality. It occurs in long-standing temporal lobe epilepsy, and it is the consequence of repeated seizures that involve the limbic networks. What we see here is hypergraphia, compulsive and detailed writing, not necessarily creative. Hyper-religiosity, intense religious or philosophical preoccupations. Hyposexuality, reduced sexual drive. Viscosity, which is sticky and prolonged conversations. Many of these people have great trouble in terminating a discussion or terminating an argument. And I'll take you back to my description of Vincent van Gogh in one of my earlier podcasts, where we talked about how his problem was terminating an argument. And it was during an argument that he was having with Paul Gauguin that he ended up getting so angry that he acted out terribly, and of course that became the subject of the man with a bandaged ear. And Vincent van Gogh also had temporal lobe epilepsy and did show many features of the Geschwind syndrome. And finally, circumstantiality, which is tangential speech and excessive detail in speech. A person is unable to control or hold themselves and ends up saying way too much. Quite the opposite of the Geschwind syndrome is the Lewy syndrome, which is reflective of a primitive release. Here, after temporal lobe damage, often bilateral temporal lobe damage from stroke, trauma or infection, the most common infection being hepatitis B encephalitis, patients exhibit primitive behavioral patterns, a stark contrast to Geschwind's structured organization. Here, hyperorality, putting various objects into the mouth, hypersexuality as opposed to the hyposexuality of Geschwind syndrome, visual agnosia, not being able to recognize familiar faces or objects, placidity, loss of fear and aggression, and compulsive exploration, examining everything. These become the key features, and in many ways the Geschwind syndrome, which involves the temporal lobe on one side usually, and the Lewy syndrome, which is often bilateral damage, are opposites of each other, and one reflects an enduring personality style shaped by years of seizure activity. The other reflects primitive release after acute destruction. The prefrontal cortex is really the conductor of human behavior. It conducts our behavioral orchestra through three key regions working in harmony. There is the dorsolateral prefrontal cortex, which is the project manager, planning, organizing and problem solving. There is the orbitofrontal cortex, the diplomat, reading social cues and adjusting behavior. And of course, there is the medial prefrontal cortex, the engine generating motivation and drive. And I will point you to the more detailed presentation that I have made on the frontal cortex and its various regions. Now, while these regions falter, we see disorganization, disinhibition, and apathy. With the dorsolateral prefrontal cortex, executive control and planning are lost. With the orbitofrontal prefrontal cortex, value assessment and decision making are lost. With the medial prefrontal cortex, self-referential thought and regulation are lost. And with the limbic system being affected, emotion and memory integration is lost. And these regions don't work in isolation. They form intricate networks with the limbic system, our emotional brain. Indeed, the limbic system is the oldest part of the mammalian brain, and it's what you and I share with the humble rat. And it houses within it our center for memory, the hippocampus, and our center for emotion, the amygdala. So you can understand how important this part of our brain is. Together with the frontal networks, it creates an integrated personality that we recognize as ourselves or as other people. When these networks are disrupted, behavior changes before memory fails, before movement stops, or before speech is lost. So what one must understand is that biology does not diminish humanity, it explains it. Changes in behavior are not always willful. They don't always represent moral weakness. They could be biology seeking expression, and understanding of this can bring compassion. For families, understanding these changes can be liberating. It shifts the blame to biology and opens the door to appropriate support. The future of neuroscience is about looking at the brain as networks over regions and going from which brain region is damaged to which networks are disrupted. And we must understand, therefore, that behavior emerges from circuits and not from locations. Our task is to diagnose with precision, treat with compassion, and support families with understanding. Behavior, therefore, is not an afterthought. It's the brain's mirror. Behavior reveals when the brain is faltering. The changes are biological and not volitional, and understanding can transform care. When behavior changes, it's the brain's way of asking us to listen. I hope you found this podcast informative. If you liked our podcast, please do subscribe and share. We are on Apple, YouTube, and Spotify. Thank you for listening.